Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and this week I want to get into AV nodal reentry tachycardia. This is a regular, narrow complex rhythm with a ventricular rate that's typically greater than 160 beats per minute. What we typically see in patients with AVNRT is that the rate is higher than their maximum heart rate should be based on their age. This dysrhythmia results from the presence of a reentry circuit in the AV node. The circuit conducts down the bundle of His, resulting in a narrow, complex QRS, and generates retrograde conduction into the atria. AVNRT is often referred to as paroxysmal supraventricular tachycardia, PSVT, or simply as supraventricular tachycardia, SVT, but it's important to understand that SVT is a bit of an umbrella term. It refers to any tachydysrhythmia that originates above the ventricles, and that's going to include things like atrial fibrillation and flutter. When we see a patient present with a regular, narrow complex tachydysrhythmia, there are four major things that should be going through our mind as possibilities. This could simply be sinus tachycardia. It could be AVNRT. Obviously, that is the topic of the podcast. It could be orthodromic atrioventricular reentrant tachycardia, or AVRT. Fortunately, that's going to be managed very similarly to AVNRT. Or it could be atrial flutter with something like a 2-to-1 block. If the rate is around 150 plus or minus 5 to 10 beats, you want to consider atrial flutter with that 2-to-1 block. The most common finding in AVNRT on the EKG is a narrow complex regular rhythm, and again with a rate that exceeds the theoretical maximal heart rate for the patient. So 220 minus age is theoretically what we think about. If the rate is higher than that, consider AVNRT. When you look at the patient's rhythm strip or on the monitor, what you're going to see is an exquisitely regular rhythm. You're at the bedside, the patient's going at 180 beats per minute. You walk away, you come back, it's still 180 beats per minute. Every time you look, it's 180 beats per minute. That is more likely to be AVNRT than something like sinus tachycardia, where there will be some variation in that rate. Even when the patient just simply takes a breath, there might be a little bit of variation. AVNRT, on the other hand, is going to be exquisitely regular. Another common finding on the EKG that we have to be aware about are ST depressions. Those can be fairly diffuse, and we're going to come back to the relevance of this in a little bit. While the classic presentation of AVNRT on the EKG is that narrow complex rhythm, we can see AVNRT with aberrancy. And here you're going to have a wide complex for that QRS instead of that narrow tight interval. This can make it difficult to differentiate AVNRT from ventricular tachycardia. There are a number of algorithms that have been constructed, including things like the Brugada criteria, but overall, none of these are perfect, and the sensitivity and specificity varies quite a bit. In general, if the patient has a wide complex regular tachydysrhythmia, we should start by thinking that is ventricular tachycardia and then work our way backwards to something else. If the patient has AVNRT with aberrancy and you treat it as if it was VTach, nothing bad is going to happen to that patient. But if they have VTach, you think it's AVNRT with aberrancy and you treat it that way, there can be some worse outcomes. We'll link to a post in the show notes that discusses a little bit more around that issue. Let's go back from the EKG to the bedside. So the patient comes in, you get the EKG, looks like AVNRT. What are our management priorities? We start with the things that we're really good at. We're going to check stability. We're going to consider whether we need to put in an IV, give supplemental oxygen, put them on a monitor, and then our goal is to convert the patient back to sinus rhythm. If the patient is unstable, and what we're talking about with unstable is that they have evidence of end organ malperfusion, if they have frank hypotension, those are things that we are going to be more concerned about. And in those cases, we're going to go directly to electrical cardioversion. Electrical cardioversion in patients with AVNRT has an extremely high success rate, and so that's going to be the quickest way to terminate that tachydysrhythmia. If the patient's stable, we have a lot more options that we can get into. We can try some non-pharmacologic approaches, we have chemical cardioversion, and then ultimately we can still go with electrical cardioversion. When we look at non-pharmacological therapies, we're talking about things like vagal maneuvers. This is having the patient bear down, trying carotid massage, all of those Valsalva maneuvers. The big one that got very popular back about 2015 is the postural modification on the Valsalva. Again, we will put a nice link to that in our show notes for how to do that. The syringe technique is another way. There's lots of these different approaches. I've had varied success with all of them. I don't think any of them are great, but there's something that's reasonable to try while you're establishing IV access and considering which chemical you want to use for cardioversion. I did say which chemical. Most of the time we are defaulting to adenosine, but there are a lot of different options here. Adenosine is a reasonable drug to use. It causes an abrupt slowing of AV conduction. When you push this, and you got to push it really fast for it to work, you're going to see a sinus pause and then resumption into a sinus rhythm if it's successful. Because adenosine has to be pushed very rapidly, there are two ways that this can fail. You can have the patient where you push the drug, it never reaches the heart, and that's a failure of administration. You can also have patients where it's pushed, it reaches the heart, it causes the sinus pause, but the patient goes right back into AVNRT. That's a little bit of a different fail, but it is a fail nonetheless. The dose for adenosine is 6 milligrams to start. That can be doubled to 12 milligrams. And again, it's got to be a fast, rapid IV push. So you want a reasonable size line, 20 gauge or larger, at the antecubital fossa or more proximal to the heart. The further that IV is away from the heart, the less likely your adenosine is actually going to reach the heart to have its effect. Though adenosine is the default medication for many folks, I actually prefer to use a calcium channel blocker instead. You want a non-dihydropyridine calcium channel blocker for this particular conversion, and that's typically going to either be verapamil or diltiazem. In the US, verapamil, sometimes a little bit hard to find, but diltiazem is going to work just fine. The non-dihydropyridines are class 4 antidysrhythmics that cause slowing of calcium channels and as a result, slowing of conduction through the AV node. The studies that we have to date show that verapamil is just as successful as adenosine in breaking the tachydysrhythmia, and actually the calcium channel blockers can be a little bit more useful because they're less likely for the patient to rebound back into that AVNRT than you are with the adenosine. If you're using verapamil, the dose is 0.07 mg per kg, usually about 5 milligrams given over 2 to 5 minutes. If I'm using diltiazem, I typically will go with 0.3 mg per kg, around 20 milligrams, again over 2 to 5 minutes. The reason I prefer using a calcium channel blocker to adenosine is the smoothness of its onset. Adenosine causes that rapid slowing of AV conduction, it causes that sinus pause, and it makes patients feel like impending doom is coming to them. Not such a great feeling. And I've had a couple of patients with recurrent AVNRT who say, I don't want that drug. They remember the drug they got, they remember the feeling from the adenosine, and they say they don't want it. So I tend to use diltiazem as my chemical cardioversion drug of choice. If those drugs don't work, synchronized cardioversion is an extremely reasonable route to take. Honestly, you could take that route instead of using one of these chemicals, but it does take a little bit more rigmarole to get electrical cardioversion set up. You're going to have to do a little bit of a procedural sedation for the patient as well. If you do electrical cardioversion, the dose that is typically quoted is somewhere between 100 and 200 joules. I tend to usually go with the higher end, 150 or 200 joules for that conversion. And I can honestly say I've never had a patient that I gave electrical cardioversion to who didn't convert on the first shock. I mentioned before how many of these patients on their EKG, they're going to have ST depressions. And it's important for us to think about what those ST depressions mean and if they should change the way we manage the patient. Those ST depressions are an electrical phenomena that has to do with AVNRT. It is not really a sign of ischemia. And in fact, AVNRT or SVT is an extremely rare dysrhythmia to have during an ACS event. Because you're often going to see those ST depressions, you shouldn't necessarily act on those in terms of how you're going to continue to work up this patient. What most experts recommend is to convert the patient, and then maybe 5-10 minutes after that conversion, get a repeat EKG and look to see if those ST depressions have resolved. The vast majority of the time, the patient's EKG looks totally fine. There are no ischemic changes. And when you go and talk to the patient and you do your history and your physical after conversion, the patient doesn't really have ischemic type symptoms. So in that set of patients, which is the vast majority of patients with AVNRT, you shouldn't be obtaining a troponin and you shouldn't be working them up for acute coronary syndrome. While we have good evidence telling us not to do that, we also have evidence telling us that in many cases, people do get troponins, and in many of those cases, those troponins are positive. However, those troponins are not representative of a type 1 myocardial infarction. They're not telling us that this patient has a coronary occlusion that needs to be intervened upon. What they're usually telling us is the patient has a type 2 MI. This is a rate-related phenomena, and that troponin is not really important in terms of acute coronary syndrome. However, this can become very difficult to manage and to work through in your head. I got the troponin, it was elevated, the patient had a tachydysrhythmia, I should probably keep him in the hospital, put him on telemetry, get serial troponins, have cardiology see them, and possibly get evocative testing for possible ACS. probably not the way to go. And so what we should be doing instead is not getting that troponin at all. What we should do is convert the patient, talk to them, get a repeat EKG. Most of these patients are not going to have, in fact, the vast majority of them are not going to have ischemic symptoms or ischemic changes on the EKG, and no troponin should be obtained. If they happen to have ischemic symptoms afterwards in that small subgroup, then you go ahead and treat them as you usually would for ACS, a totally reasonable approach. But the vast majority of patients with AVNRT should have no assessment for ACS because they're not going to have symptoms that's concerning for that. However, if you get a troponin, it might be positive and it might lead you down the wrong direction for management of that patient. As far as disposition, most of these patients can be discharged home after termination of the tachydysrhythmia. If your post-conversion history and physical and EKG give you some other reason to do a workup, that's totally fine, but that is going to be an uncommon situation. So let's hit some take-home points before we wrap up for the week. Number one, AVNRT is a common tachydysrhythmia. It results from a reentrant loop within the AV node. The rate is typically going to be higher than the theoretical maximum heart rate for that patient. And when you look at the monitor, their rate is going to be exquisitely regular. You're not going to see any P waves on EKG. That's also obviously a good tip that you're dealing with AVNRT. Number two, if the patient is unstable with AVNRT, you can go ahead and proceed with immediate synchronized electrical cardioversion. Don't forget the procedural sedation and analgesia. If they are stable, then you can consider vagal maneuvers followed by chemical cardioversion with something like a non-dihydropyridine calcium channel blocker. We're talking about verapamil or diltiazem. You could use adenosine, or you could go ahead and do electrical cardioversion if those things fail. Finally, troponin testing should not be the standard practice for patients presenting with AVNRT. What you really want to do is not pay attention to those ST depressions while they're in AVNRT, but instead talk to the patient after cardioversion, see if they have ischemic symptoms, take a look at a post-conversion EKG, and then make a decision of whether you need to work them up. It's going to be the vast minority of patients that are going to meet those criteria. Now, that's it for the Rebel Core Content Podcast this week. We'll be back in 2 weeks with another cast. In the meantime, don't forget to pop on over to the site, check out all of the great posts from our faculty, check out the show notes for this episode, which is going to have some great links to follow up and read more about AVNRT, some of the other tachydysrhythmias as well. And we'll see you back in a couple weeks.